Hey, what's up? How you doing? So today we're talking about hemorrhoids. Okay, hemorrhoids. It's kind of a dirty topic, but it's a necessary topic. People come in all the time complaining of bleeding from their butt, painful bowel movements, it hurts when I poop, I've got something hanging out of my butt. There's always a complaint. Sometimes this is from a hemorrhoid. Sometimes it's from an anal fissure. Sometimes it's from a colon cancer or an anal cancer. We're kind of going to address those in separate topics because they're big but small. So first things first, what's a hemorrhoid? It is a distended swollen vein in the rectum and anus caused by straining during bowel movements. There are two types of hemorrhoids. It's either above the dentate line or below the dentate line. The interesting thing about this dentate line is this is the junction between the portal drainage and the systemic drainage. What that means is anything above the dentate line, so from this line up into your rectum, is drained through your liver. If it is below the dentate line, it drains in the muscles, through the subcutaneous skin. This is important because internal hemorrhoids above the dentate line don't cause pain, they cause pressure. Anything below the dentate line, an external hemorrhoid, causes pain because it's basically the same as getting your skin pinched or cutting your skin. So the sensation is completely different. So that is why this dentate line is so important. A weird fact is anytime on the internet when you hear people talking about how they are doing enemas with alcohol and getting drunk pretty quick, it's because when you put it above the dentate line, it actually is absorbed directly into your bloodstream and then it goes into your liver. So it's a quicker route to the bloodstream. So the dentate line outside of doing alcohol enemas is a really important line, and it helps us determine what the next step is. The reason this is important, not only because of the signs and symptoms, it's because a external hemorrhoid can usually be fixed in the office by draining it, versus an internal hemorrhoid needs to either be excised or ligated. We'll get into treatment a little bit later. Right now, let's talk about the symptoms that traditionally would bring you into the doctor's office to have your hemorrhoids evaluated. Painless venous blood while defecating. Again, if you're having painless bleeding, it is usually from an internal hemorrhoid that is above the dentate line. If you have painful bleeding and you have a hemorrhoid, it is usually an external hemorrhoid and is below the dentate line. Pruritus is basically itching, but that itching occurs when you have healing or stretching of skin. External hemorrhoids can cause stretching, which can cause you to itch. It can also be from small localized infections that can cause you to itch as well. Fecal incontinence, or the inability to control your poop, just kind of falls out on its own, is usually a late sign of internal hemorrhoids, not external hemorrhoids. Palpable lump can be one or the other. If you have a grade 2, 3, or 4 hemorrhoid, we'll get into that a little bit later, internal hemorrhoid, that can cause a palpable lump. If you see a purple lump on the outside of your butthole, that is an external hemorrhoid. Both of these kind of give you a sensation of fullness when they're engorged. You have to remember that a hemorrhoid is essentially a shock absorber. It is a vein that when you overuse it, whether it's constipation or multiple bowel movements, it's there to just kind of absorb all of that increase and decrease in size of that sphincter. When you overuse it, that shock absorber or that vein gets engorged. So this is traditionally dark bleeding. If you start having bright red blood, you're either looking at a fissure or a colon cancer. As far as the grades of hemorrhoids, we typically grade internal hemorrhoids, less so external hemorrhoids. With an internal hemorrhoid, again, above the dentate line, there are usually 4 grades. The first grade is grade 1. That's where it bleeds spontaneously, but there's nothing palpable or nothing that you can see. Grade 2, it prolapses out of the anus and is bleeding. But grade 2, they spontaneously go back in on their own. So what happens is that vein, when it decompresses on its own, it'll go back inside. A grade 3 is one that is bleeding and hangs out. These don't go back in on their own because they're so swollen, so the only way to get them back in is to push them back in. A grade 4 is bleeding, prolapses, so it's hanging out, but you can't push it back in. The reason you can't push it back in is because it's gotten so swollen and edematous that it won't fit back in. Those traditionally are described as strangulated hemorrhoids. Those are the ones that we see that are hanging out. You can see mucosa, and they typically have ulcers in them. There are a couple videos on the YouTube channel you can see where we've actually done some really bad grade 4 hemorrhoids. Grade 1 does not require surgery. You can pretty much do a stool softener and that's it. Grade 2, you can do surgery or a stool softener and the results are varied. Grade 3 and grade 4 both require surgery. As far as treatments, let's start talking about that. The first thing that we have to do with treatment is figure out whether someone has an internal or an external hemorrhoid. That usually requires a good history, but also evaluating it by looking at the hemorrhoid. Yes, you have to show your booty when you go see the doctor. The easiest way to do this is to look first, and sometimes requires a digital rectal exam. That's where we put our finger up your butt. If that doesn't work and we can't see or feel what we need to by just looking and doing a digital rectal exam, we have to proceed with anoscopy. Anoscopy is basically a small camera or scope that we put in your rectum that we can look and see at the dentate line and about 2 centimeters above. Most people don't have stool right at the dentate line unless they have to poop right now, so you don't require a prep for this. If we don't see a source of bleeding, then that's when we start talking about colonoscopy or flexible sigmoidoscopy. Once we figure out whether you have an internal or external hemorrhoid, we have to decide what the next best course of action is. If you have an external hemorrhoid and it happened one time and you don't have any other risk factors, a lot of times we treat that conservatively by changing lifestyle, increasing fiber, making sure that you're drinking enough water so that your stools are soft, as well as doing stuff like 6 baths. Actually, we're not doing this. I'm a steroid hater. I think steroids just cause you to feel better a little quicker, but the problem is they can cause ulcerations and bleeding, so they really don't help you that much. Nitroglycerin essentially dilates those veins so they can drain quicker, so you can maybe take a external hemorrhoid, allow it to drain, and then if you had an episode of chronic constipation, this will help you drain it, and then it may not happen again if you can change your dietary lifestyle. The same is true for an internal hemorrhoid as well, with a couple little small things. With internal hemorrhoids, once you start having them prolapse, so you're outside of a grade 1, you will have to have surgery at some point because that tissue just becomes more redundant over time. Now, if you do stool softeners like Colace, mineral oil, anything to get your stool the consistency of toothpaste, you will prolong that. So instead of it happening in 5 years, it could happen in 15 years. So conservative management does work for external hemorrhoids and grade 1 and grade 2 hemorrhoids. Grade 3, at some point, you're going to be so uncomfortable. Grade 4, you absolutely have to have surgery. Now, surgery. For an external hemorrhoid, this can be done in the office or in the emergency room. There are two ways to do it. In the emergency room, they just drain it, squeeze it, get the clot out, and that's it. It will heal and come back. In the surgeon's office, we excise them in the office by localizing them with lidocaine, completely excising the hemorrhoid, and it never comes back. But again, that's for an external hemorrhoid. Internal hemorrhoids, completely different. You have to do remove the hemorrhoid or remove the vein. Now, we used to do something called banding or rubber banding these to ligate them. The problem with that is the dentate line. If you are not above the dentate line and you put the rubber band on, it will be a true pain it will hurt, you will scream, and then once it dies, you have this foul smelling fluid that comes out of your butt for a little while, and patients just kind of don't like doing it. So we stopped doing that, and we now have a better procedure. It's called a stapled hemorrhoidectomy. That is where we use a stapler device in the operating room, and we completely cut out all of the hemorrhoid complexes. There are three internal hemorrhoid complexes that extend out. There's a right anterior, right posterior, and left lateral. When you do a stapled hemorrhoidectomy, you can get all three complexes. That is the way that we do it right now the majority of the time. There's another way, which is the old school way, where you just remove the complex that is causing the problem. The issue with doing all three for an internal hemorrhoidectomy is that if you do that, you can actually get strictures or narrowing of your anus. So what we try to do is only do two at a time. So some people just have one, some people have two. Those, it doesn't matter whether you get a stapled procedure or a traditional procedure. But if you have all three complexes that are inflamed, you do want a stapled hemorrhoidectomy. And then if you have all three hemorrhoid complexes inflamed, then you absolutely want a stapled hemorrhoidectomy. Again, simply because you don't want to cause a stricture or narrowing during the procedure. Now, after you've had the procedure, there's a little bit of follow-up that has to occur. First thing, of course, is pain management. You're pretty sore for the first 3 or 4 days. After that, it gets better. Anytime you have any buttocks procedure or anus procedure, a sitz bath is always a good idea. This is fancy talk for if you have a shower head that you can detach from your shower and just squirt it everywhere, is essentially using that to wash the stool out your butt. It does a couple of things. One, it makes it easier to get yourself clean because you don't have a paper towel rubbing on it and it doesn't cause pain, but it also helps relax those muscles. So doing a warm sitz bath helps with pain and keeping yourself clean. High fiber diet is nice because it does make your stools a little more bulky, which makes them a little softer. The problem with a high fiber diet, especially post-operatively, is that it can be too bulky and then can cause pain. The most common complication after a stapled hemorrhoidectomy or any type of hemorrhoid procedure is urinary retention. So if you're doing this on a male, you have to make sure that they do or don't have a history of urinary retention secondary to an enlarged prostate. If they do, just let them know that if they have trouble peeing after the procedure, they need to come back to the hospital, call the physician's office, or go to the emergency room. UTIs can be more common in females than men after the procedure. And again, the bleeding that you had before will stop, but it will be a little bit worse right after surgery. So a little bit of bleeding is expected, and it can take up to 4 weeks for this to heal, so it can take up to 4 weeks to stop. Fecal incontinence and an anal stricture are more complications than after surgery, and those are the things that we try to prevent. That's why, again, we only do 2 hemorrhoids when we're doing it the traditional way. and we don't want to develop a stricture. The biggest thing about hemorrhoids is, one, you need to make sure that it is not something else. So once you see your clinician, they may say, okay, this is a fissure, completely different treatment, or we don't see any hemorrhoids, we need to do a colonoscopy before we do any other procedure. Other than that, hemorrhoid pretty much is a pain in the butt. We have good treatments for it, and a pretty simple operation for a very painful problem. Thanks for watching. After this, we'll cover anal fissures, and that kind of will complete the booty bleeding topics. Take care.